Hello guys, my name is Dr. Laith Abu Mahfouz. I am a medical doctor as well as a specialist in anesthesia and intensive care. I like to lecture a lot and give lectures. I like virtual teaching. That's why today we are going to speak about IV anesthetic, subject which is very important in pharmacology, anesthesia, as well as in physiology. So, my friends, let's start. Today we are going to talk about an important subject in medicine. We are going to talk about the pharmacology of anesthesia, especially the IV anesthetics. First of all, these drugs are used specifically for anesthesia, and sometimes they are used by other specialties for things like sedation. These are the cornerstone of anesthetic drugs. Let's start with the IV anesthetic definition. So, here, if we want to define the IV anesthetics. Okay, they are any medications that causes, I will use shortcuts for words, causes loss of consciousness, abbreviations I mean, loss of consciousness when given intravenously in one arm brain cycle. Okay, so these drugs when given intravenously, what does that mean? Intravenously. Now, if you go to a theater, operating room, or hospital, you can give drugs by many ways. These are called the routes of administration. Firstly, oral. You might give it rectal. You might give it in the vein. You put something called a cannula. It's the way we give a drug in our veins. So this one is called intravenously. Okay, you can give it through injection in a muscle. This is called intramuscular. Now, these anesthetics, when they are given through the intravenous route, they cause loss of consciousness. Now, currently I am conscious. I can speak, I can understand, I can see. But when someone is comatose or sleeping, especially if he's not doing so voluntarily, this is called loss of consciousness. So these drugs can cause loss of consciousness when given intravenously, but they have to be given in the appropriate doses. So if you give a little bit of these drugs, they won't cause loss of consciousness. Now this one-arm brain cycle, what does it mean? This one. Now, we said we can put something called intravenous catheter or cannula. You can put it on the hand, you can put it on the feet, you can even put it in the neck, you can put it here. Now, if you put it on the leg, this will be called leg brain cycle, for example. But here it's called one-arm brain cycle. It's the time the body needs to deliver the blood from the arm to the brain. So these drugs, which our lecture is about, they move from the arm to the brain in one arm brain cycle. So the cycle here is a duration, okay? It's an amount of time. How much? It's around 10 to 14 seconds, okay? So look how these drugs are so special. They can make you lose consciousness in only 10 seconds. That's magic. And I have always said the guy who invented or found Propofol, he's a magician. And in my humble opinion, he needs he should have won some prize like Nobel Prize or etc. But it's not my business or job to decide. So we will go back to this one-arm brain cycle. So these drugs, when you give them in the arm, they need 10 seconds to make you lose consciousness. Okay. Today, we are going to talk about many drugs. One of them called ketamine, okay, has an exception. Also, it's an IV anesthetic. It needs 90 seconds to make you lose consciousness if you give it in the arm. Okay, now, if we want to make an outline for this lecture, we can talk about the drugs, the name of the drugs we are going to talk about. So here is IV anesthetics. Okay. They are divided by many classification. So you can say rich drugs, you can say poor drugs, you can say tall drugs, you can say short drugs. But if we choose chemical classification, you will have two large family. The first one here and the second one here. What's important about this family, it's not a group of individual drugs that belong to the same family. Rather, each drug consists of a subfamily that are different. These subfamilies are different from each other, but they are in this family. You will understand later. So, this group is called barbiturate, and this group is called non-barbiturate. Okay? Now, the barbiturate, let me change the color here. Yeah. The barbiturate, today we will talk mainly about thiopental and a little bit about methoxytal. Okay, now here, the non-barbiturate, we said it consists of many drugs. Today we will talk about Propofol. We will talk about ketamine, we mentioned previously. And the last drug is etomidate. So if someone wants to understand the IV anesthetics we use in anesthesia, you have to be familiar with these 5 drugs, or at least 4 drugs if we omit methoxytal. Now, these drugs, we said previously, they are among one group called non-barbiturate, but each one of them is in a separate family. They don't share a chemical characteristic that's uniform for all of them. The only thing they share is that they are not barbiturate. Let's say barbiturate are American people. These group are non-American people. This guy might be Asian, this guy might be European, and this guy might be African, for example. Okay, now, if we want to start the lecture, we have to understand how these drugs work. Now, we spoke about that the drug is given intravenously. Also, one of them can be given by other routes. We will say about that, speak about that later. If we start with how these drugs work inside the body. Anything in the body needs a receptor. Okay, so anything in the body needs a receptor. So these drugs come from outside, from the factory to the cannula, and finally to the inside the human being, to the blood. Finally, they try to search for their receptor to give their work. Okay, now, as you can recognize from the definition of the IV anesthetic we spoke about earlier, these drugs wants to make loss of consciousness. So if you choose a system that these drugs will work on, what will you choose? Let's say you have central nervous system, you have the GI system, you have the cardiac system, you have, let's say, hematological system, you have renal system. What will you choose one of these? Of course, what causes loss of consciousness is the nervous system. Okay? And specifically, the central nervous system. So these drugs, their main site of action is the central nervous system, but they can exert effects on other systems as well as any drug in the body. Sometimes you take a drug for your stomach upset, but this drug can cause something in your eye, for example. This is not something strange in medicine and in pharmacology. Okay, now to work on the central nervous system, this drug, let's say this simple is the drug, needs a receptor to work, and this is the symbol of the receptor. Now, these receptors are not one type, and these drugs, as we say, are multiple families. So they need to work on receptor. Each drug work on different set of receptors, or a single receptor that is different from the single receptor the other drug work on. Okay. Now, for these drugs to cause loss of consciousness, do you think we have to stimulate the central nervous system or inhibit the central nervous system? I am hearing you answering, we should inhibit, because I want to make the patient sleep. I want him to make loss of consciousness. I don't want to stimulate him. If I want to make him happy or stimulate him, I might give him something like cocaine, but I won't do that because it's bad for health. Or other drugs like amphetamine, for example. I wouldn't do that. I was just joking with you. So these drugs stimulate the central nervous system, but not every stimulation is something good. That's why our physiology needs to remain, most of the cases, at its basic side. At its basic state, without stimulation or inhibition. Okay. But in anesthesia, we inhibit the CNS. Why? Because the patient is going to have a surgery. We don't want him to feel or her to feel pain. We don't want them to have physiological changes. Their heart will accelerate through or due to pain, and their heart will accelerate due to stress or fear or anything else. And this might lead to bad things like myocardial infarction, which is heart attack, and similar things. So we have temporarily to inhibit the CNS. Now, if we go back to the drug, here we have drugs and we have receptors. If we go here and make a table, okay, we will put the drugs here and the receptors here. Okay. The interesting thing about the CNS is that we have stimulatory and inhibitory receptors. Not all the receptors are stimulatory, neither all of them are inhibitory. Now, here we have the inhibitory receptors, and here we have the stimulatory receptors. I would like, let's go here for a second. The inhibitory group, for me, this is not like scientific thing, but something for memorizing. I would like to call it G receptors. Okay, why G receptors? Because it consists either of GABA receptors or glycine. Okay, but we have the stimulatory receptors. I would like, for the same reason, to call them the N group. We have NMDA, and we have nicotinic neuronal receptors. So we have two sets of groups, inhibitory and stimulatory. As we said previously, our IV anesthetic drugs need to work on both of these receptors. Okay? We have to inhibit the CNS. To inhibit the CNS, either you make the inhibitory receptor more powerful, or you have to make the stimulatory receptor less powerful. Okay? So our drugs either potentiate these receptors or make them work more, or inhibit these receptors or make them work less. So remember, the G group is inhibitory and the N group is stimulatory. We have to potentiate the G group or inhibit the N group. Let's go back to our table here. We put the inhibitory or the G group here and the stimulatory, the N group here. Let's make our drugs be put here. Firstly here, second, and third. First of all, we have two drugs, Propofol, and I like to color it in green because I think Propofol is like Hulk. If you watch the Avengers, you know the Hulk character. So Propofol is the Hulk for me. So I will make Propofol in green. I will mention later why it's Hulk. And I will make other drugs in red. Here, thiopental. So Propofol and thiopental have the same or share the same mechanism of action. And here, ketamine and etomidate is here. Well, red color is so suitable for ketamine because it increases everything in the body. It's a very powerful drug, yet it's dangerous drug, like the red color might show. Now, let's go back here. I will start with the ketamine group because it is the easiest one to memorize. We have here NMDA, nicotinic, and here GABA and glycine. Okay, now here ketamine inhibit NMDA. This is the only way it works. Here none, N for none, here none, none. So ketamine only work on NMDA receptors here by inhibiting NMDA receptors. It doesn't work on the other receptors. Now, Propofol and thiopental, they increase GABA, okay, and they increase glycine, but they decrease the nicotinic because it's stimulatory, but they don't affect the NMDA. So N for nothing. Lastly, etomidate works only on one receptor, which is GABA, by increasing GABA. And here nothing, nothing, nothing. Now all of these receptors, they are important, but I want to speak about the most important one of them, which is GABA. In the body, or let's say this is the receptor, each receptor in the body needs a substrate to bind to it. So these, in physiology, which is the normal behavior of our body, we have these receptors. They exist for a reason. Okay, so inside the body also, we need a substance to bind to this receptor. So this substance, I will draw it as a circle. In contrast to the drug, which I draw as a star, because the drug something is from outside the body, something that is manufactured, but the circle is something natural. Now, the circle, which is a substance inside the body, is called substrate. So remember, from substance, substrate, it binds to the receptor. When it binds to the receptor, okay, it makes our body do a certain function. For example, when acetylcholine bind muscarinic receptor, acetylcholine is something, a natural substance in our body. When it binds to muscarinic receptor, it might make you go to the restroom, okay, and urinate. So this function of urination is a bond between the binding of a substrate and a receptor. Okay. Now, sometimes the receptor and the substrate doesn't have different names. Here they have different names. Sometimes they have the same name, which is like GABA substrate and GABA receptor. So here you have to differentiate between two things. The substance might be called GABA, and the receptor itself might be called GABA. Okay, for example, Algeria is the capital of Algeria. Both the country and the city have the same name. So here is the GABA receptor, not the GABA substance. Here is the GABA substrate, but here is the GABA receptor. Now, this receptor is called a Bentameric receptor. Why? Because bentamine, it consists of 5 subunits, like the pentagon. The pentagon is called the pentagon because it consists of 5 lines. Here, it consists of 5 units. We can see 2 alpha here, 2 beta, and 1 gamma. We must know these letters or symbols very well. Now, inside these subunits, between them, they are hollow like this. Between them is a channel that allows the passage of chloride. You know that a chloride is a negative ion. So if you increase the passage of a chloride, you will make the cell more negative and you will inhibit the cell. That's why GABA is an inhibitory receptor. Now, our drugs, when they work on the GABA, they increase the passage of the chloride, so they inhibit the central nervous system more, and that's why you sleep when you take Propofol or thiopental. But, as we said earlier, it have many subunits. The physiological substance substrate GABA, it binds to the alpha subunit, while our drugs today binds to the beta subunit, like the Propofol or the thiopental. Finally, we have the benzodiazepine, like midazolam. These drugs are used for sedation rather than loss of consciousness. Consciousness is a spectrum rather than 2 states of awake or sleep. Sometimes you are awake but drowsy or sleepy. That's what benzodiazepine makes people do. It makes them sleepy, drowsy, less alert, less awake. So benzodiazepine, like midazolam, they bind at the area between the alpha and the gamma area. So we understood why these drugs are called IV anesthetics. We understood the mechanism they work inside the body. We have to speak about these drugs separately now. We said the IV anesthetic consists of 2 major families, the barbiturates and non-barbiturates. We will start with the barbiturate. Okay, we have to understand what's the barbiturate made of. It's made of a basic unit called barbituric acid. This unit is made by combination of 2 substances, as we will. Acid here consists of the combination of urea and malonic acid. But we have many barbiturates, not only the thiopental. We have a lot of barbiturates we use in the neurology for like anti-epileptics, etc. So what is the difference between these different barbiturates? It's what we add to this unit. This is the basic unit. What we add above it makes it a specific drug. Now, or not, something called firstly types of drugs. The barbiturate consists of 2 families of drugs, oxybarbiturate and thiobarbiturate. Now, the only difference between the 2 groups is the prefix oxy and thio. So here, oxy, I think you know, it represents oxygen, and thio, I think you believe it represents sulfur. Okay? So the difference between the oxybarbiturate and the thiobarbiturate is putting an oxygen atom rather than a molecule, or a sulfur atom on the barbituric acid basic unit. Today, we said one of the major 4 drugs we will talk about is thiopental. Thiopental. So, my friend, do you think thiopental is an oxybarbiturate or a thiobarbiturate? Of course, you will say it's a thiobarbiturate because it contains the thio prefix. You are perfect. So, thiopental has, or thiopentone, depending on where you are, has a sulfur atom. So, the thiopental is basically made of an oxybarbiturate called bentobarbitone. This bentobarbitone, we omit the oxygen and put on instead of it sulfur atom. Okay, now we have the thiopental. But the question here is why the manufacturer, company, or the scientist that discovered thiopental wanted to be a thio drug, not an oxy drug. Why putting lots of efforts to change it and omit this oxygen and add sulfur? This is not an abruptly done thing. It's a studied thing. That's why we do research. That's why we need labs. And that's why we can improve humanity. Here, the reasons are, firstly, thiopental or thiobarbiturate are more potent. More potent means they are more powerful. And they are easily or easier to be excreted from the body. They don't need to stay in the body for a long time. So, we have our drug here, thiopental, which we said causes loss of consciousness in 10 to 14 seconds. Now, each drug in the world has a form. When you take something for your head pain, like paracetamol, it's like a pill. Now, thiopental is not a pill. You have something called an ampoule, inside which you have here the thiopental. So the thiopental might be in the gas status or in the solid or liquid status. Well, it's in the solid, exactly a powder status. So the thiopental comes as a powder. You have to put this powder with another liquid, let's say normal saline or distilled water, and after you put it with distilled water, it becomes a solute inside the water, and you can give it inside the cannula. That's why we mix it with distilled water to make it a liquid that can go intravenously. Now, what we shall put here, most of drugs have air here, but that's not the case with thiopental. Why? In pharmacology, a general concept. Lots of drugs, if not all drugs, have isomers, which are different forms of the same drug. So we can have one drug. These drugs have 4 isomers. If you bring someone with tall hair and cut his hair, he will remain the same person. But isomer of him with short hair, and this is an isomer of him with long hair. Here we can see that thiopental or any barbiturate have two main isoforms, the keto form and the enol form. Here we have the keto form, and here we have the enol form. Look here, it say alkaline environment. So when you put the barbiturate in alkaline environment, it will transform into enol form. But when you put it in an acidic form, it will remain in the keto form. What's so important about this, the keto versus the enol? The problem is that the enol form is more soluble than the keto form. So if we go thiopental is in the keto form, it will not dissolve in the water. But if it is in the enol form, it will do so. So as the same guy previously which invented or created thiopental from pentobarbital, he will try to make thiopental into enol form. How will he do this? By making it alkaline. And how he will do this? By omitting air from the ampoule. But why? Does air increase acidity? Does it decrease the pH? Yes, it does. And why does it so? Because it contains CO2. You can search why CO2 in the human body can cause acidity on the internet or through a textbook, but mainly because it increases the hydrogen ions and it decreases the bicarb. So, specifically speaking, CO2 makes this acid, so we remove the air and instead here our friend bought nitrogen instead of air to make the thiopental in the enol form and make it soluble. The second thing is that our friend added Na CO3, which is sodium by sodium carbonate, which will later increase the HCO3 and the BH. So we have two things to make it thiopental and enol. Firstly, putting nitrogen instead of air. Secondly, putting sodium carbonate in the ampoule. Now, each drug in the world has something called percentage. This is the symbol of percentage. Let's forget about thiopental a little bit. Now, when you say a drug has a concentration of 1%, what does that mean? A concentration of 1% means 10 milligram per ml. So ml is a unit of volume and milligram is a unit of mass. But how we reach this thing? 1 ml or 1% means 1 gram and the percent 100 ml. Now transform this to milligram. This will be 1000 milligram per 100 ml. After doing the subtraction, it will give us 10 milligram by ml. So in anesthesia or pharmacology, whenever you see the percentage sign, just multiply by 10, you will have in milligram per ml. But what's important about this? When we dissolve the thiopental, we need to know how much thiopental. Here is our syringe. We took the ampoule and added to the syringe. The syringe consists of many cc's. We need to know each cc how much milligram of thiopental it contains, because depending on this knowledge, we can know how much cc's to give to this patient so he or she can sleep. Now, if we know the concentration of thiopental, we will know how much milligram in each cc. The concentration is 2.5. If you multiply by 10, it will give us 25 milligram per ml. This brings us to the next question, which is, how many cc's should I give to each patient? So if I have a child, I'm very bad at drawing, and a man, and a shorter man, should we give all of these the same amount of thiopental? I think you say no, and that's correct. But how can we know how much to give each one of them? We can't study each human being alone, because we anesthetize or treat millions of people in the world. So we depend on the weight of the patient. So here is the weight in kilograms. Here, how much we should give per kilogram. So the dose of the thiopental is 3 to 7 milligram per kg. So if this guy has 5 kilograms, we will give him around 15. If this guy have 60 kilograms, we will give him 180 milligram of thiopental. But how many cc's? We will divide this by, for example, or this by 25. We will have around 8 or 6 cc's. Do the calculations, please. So now we talked about thiopental, its concentration, and its dose. And that's amazing. Now we need to know how or what are the effects of thiopental inside our bodies, other than making us lose our consciousness. We have many systems in our bodies. Some of these are so vital and important, like the cardiac system, the respiratory system, the renal system, and our friend here in anesthesia, the central nervous system. If we understand how these organs or systems work in physiology, we will understand the effect of these drugs on these systems. Let's go to each system of these. Today we are going to speak about 4 major drugs, which are thiopental, propofol, ketamine, and etomidate. We want to understand the effect of each of those on the following systems. But before, let's talk about each system separately. If we start with the cardiac system, you know there is something called cardiac output. It's the amount of blood the heart pumps in each minute. So let's say 5 liters in volume per minute. But what's the equation, or let's say the rule of cardiac output? It's heart rate multiplied by stroke volume. Heart rate is the number of pumps your heart beats each minute. Let's say it's 60. Stroke volume is the volume your hearts pump with each beat. Okay, let's say 100 cc. So if you multiply 60 by 100 cc's, you will have this number, or around 6 liters per minute. have another equation, which is mean arterial pressure minus central venous pressure over the systemic vascular resistance. So let's remove this and put blood pressure. So if you subtract blood pressure over the systemic vascular resistance, you will have cardiac output. You might multiply by a certain number to convert for units, but this is not our subject now. The systemic vascular resistance is the resistance in the arteries in our body. So if we measure the resistance in our body, if we have the blood pressure and this resistance, we can have the cardiac out. All of these because our drugs today can either increase, decrease, or make these the same. Let's move to the respiratory system for the same reason. We have something called minute ventilation, which is the volume the lung inhales or exhales in 1 minute. So it's a volume also. Let's say 4 liters per minute. What's the equation? It's very similar to the cardiac output. It's the respiratory rate multiplied by tidal volume. The tidal volume is the volume you inhale or exhale with each breath, which is 500 ml. And the respiratory rate, it's around 12 to 20 or 10 to 20 breaths per minute. So at the end, we will have 5 liters per minute, which is the minute volume. Now, if we go to the renal system, which consists mainly of our kidneys, the renal systems, we have renal blood flow is the amount of the blood that enters the kidney, and GFR, which is a glomerular filtration rate, which is the amount of blood the kidney filters and takes substance from. CNS, we have many things like cerebral blood flow, which is the blood that goes to the brain, and we have the cerebral metabolic rate is how much the brain makes metabolism, and we have oxygen consumption in the brain is how much the brain uses oxygen, and this is related to this. And we have the intracranial pressure here. It's the pressure inside your head, and if it increases, you will have a lot of problems. So why are we talking about all of these? Because the 4 major drugs we are going to talk about today, or we are just talking about now, they affect these parameters differently. So let's make a group, or the same groups we made earlier. We have the A group, the B group, and the C group. The A group, we said, consists of Propofol and thiopental. The B group, it consists of ketamine, and the C group of etomidate. Now, what I'm going to say is not true for all the things we mentioned, but for most of them, most of the time. Propofol and thiopental, they decrease the things we spoke about, whereas ketamine, it increases the things we talked about. And finally, etomidate rather increases nor decreases the things we talked about. So let's go here. If we start with the Propofol and thiopental, they decrease everything, whether in the cardiac system, in the respiratory system, the renal, or the CNS. But there is one major difference we will talk about, which is the heart rate. and we will speak later why. So, thiopental and propofol, they both decrease the cardiac output, they both decrease the stroke volume, the blood pressure, and the systemic vascular resistance. So, if you have someone you want to anesthetize and his blood pressure is 80/50, it's not wise to use one of these drugs. Now, let's go here. These drugs, both of them, they decrease the minute ventilation, respiratory rate, tidal volume, and they decrease the renal blood flow and GFR, and they decrease the cerebral blood flow, the cerebral metabolic rate, and the intracranial pressure. If we go back here, the difference we said is in the heart rate. You have to concentrate on this, and we will explain why later. Now, let's go to ketamine. Ketamine increases the cardiac output, increases the heart rate, increases the stroke volume, blood pressure, and systemic vascular resistance. So, if you have blood pressure of 200/120, you have, or you should avoid ketamine. It also increases the minute ventilation, the respiratory rate, and the tidal volume. It increases these, and it increases these, and most importantly, it increases the intracranial pressure. Is this important? Yes, this is important. If you're having someone who just had head trauma, and most likely he's having high pressure inside his cranium, his head, it's not wise to give him ketamine. You should think of something else. Finally, our friend etomidate, it most likely neither increase or decrease. That's why when it was used in the past in many countries, it was used in cardiac surgeries, because neither they increase the cardiac work nor they decrease it. They make it stable. So let's go to our point, which is the heart rate, the difference between propofol and thiopental. Why one of these? So thiopental increases it while the propofol decreases it. Why? Both these drugs decrease the blood pressure. Let's for a minute forget about these two drugs. When you decrease the blood pressure in the body will not stand still. We have reflexes in the body that acts to counteract something that's bad for the body. So the decrease or the increase in blood pressure is something bad for you. You have to remain in the normal range for your body. So what does the body do when your blood pressure, for example, decreases? We have something called receptors. These receptors senses the changes in the blood pressure, and they transform the info to the brain. The brain makes changes to the body. So these baroreceptors, where do they exist? The ones that sense the change in the blood pressure, mainly in two sides. The carotid sinus and the aortic sinus. The carotid is a big artery that exists in the neck, while the aorta comes out from our left ventricle. It's the major artery in our body. These two sides, the sinuses, when you have a change in blood pressure, they sense the change in the blood pressure and send info to the brain. So here is the brain, and here is the receptors, both of them. How do they send the info to the brain? Through nerves. If you study about nerves, you will know something called the cranial nerves. So the heart or the aorta will send its info through the vagal nerve, which is the 10th nerve, while the carotid sinus will send its info through Herring's nerve, which is part of the glossopharyngeal nerve. The glossopharyngeal nerve is number 10. Here we have Arabic numerals. In the Roman numerals, they will be like this. So through these nerves, the info to the brain that your body is having a problem with the blood pressure, the body will start to, or will try to compensate for this. But where is here in the brain the information comes to is in the medulla. Sends info to the heart to increase its pumping, to increase the heart rate. So, what I am saying is that if you have low blood pressure, the baroreceptors will try to increase the heart rate. But if you have high blood pressure, the baroreceptors will try to decrease your heart rate. Now, both of our drugs, thiopental and propofol, they decrease blood pressure. That's why you should have increased heart rate as in thiopental. Why? Because the baroreceptor here will do this, but propofol prevents the baroreceptor from doing its job. That's why propofol, or the green one, propofol, it decreases blood pressure, it decreases the baroreceptor, so the heart rate can't increase. It can remain the same as it is, but most likely it will decrease. So now we understand the only difference between thiopental and the propofol. They both decrease everything except heart rate, which is increased in thiopental and decreased in propofol. Let's go back to thiopental. Now, each drug in our body has some problems we call side effects that we don't want to. The manufacturer wanted thiopental to make loss of consciousness, but not some bad effects. First of all, thiopental in people who have allergy can make a problem, especially in people who have severe allergy or anaphylaxis. That's why if someone is having asthma, it's better to avoid thiopental. You can give propofol and even better ketamine. Now, something else is that thiopental is anti-analgesic. So thiopental is anti-analgesic. What does that mean? You know that analgesic or analgesia mean loss of pain or decrease in the sensation of pain. So anti-analgesic will mean the opposite. So sometimes if you give thiopental in low doses, this will lead to anti-analgesia. It will increase the sensation of pain, or more correctly, it will decrease the threshold for sensation of pain. Each person have a threshold. Some people can hold a lot of pain without complaining. Some people with little amount of pain, they start shouting. So this is called the threshold of pain. These drugs mean those people who can withstand pain, they can't now do with the low doses of thiopental. Now, let's go back to something we talked about earlier, which is keto and enol form. Now, we said that enol is more soluble, and if you remember, we do two things, the nitrogen thing and the sodium carbonate thing. Now, we said we can put a catheter inside any vein in the body to give medication. But sometimes in anesthesia, we put a similar catheter somehow in the artery here, okay? Or any other artery, but mainly here. Blood pressure with each beat. Now, if you are putting this arterial line, mainly this line is not for giving medications. So try to avoid. That's why we label it, and we might put some certain label with certain color to know it's an arterial line, not venous. But let's say mistakes happen in life, and everybody can make mistakes. You, me, anybody. So if you, by mistake, gave a drug in this artery, what will happen? Some drugs will not do a lot of problems, but some drugs will do so. One of them is thiopental. Why? For unknown reasons, the thiopental, it changes into the keto form, and it precipitates, and it can close the arterial line. So that's why thiopental is one of the bad drugs to give in the arterial rather than the venous line. Now let's go to the other barbiturate we talked about, which is methoxytal. It's not as important as the other four major drugs, but we have some words to talk about. Firstly, methoxytal is an oxybarbiturate, not a thiobarbiturate. We add methyl group, this is called methyl, you have to remember this. To an oxybarbiturate, we have methoxytal, here CH3. This drug is better than thiopental. It doesn't cause the amount of allergy that thiopental causes, but this has its own problem. It can cause stimulation rather than depression of the CNS, and it can cause seizures. So, if you have an epileptic patient, try to avoid methoxytal. Now we have talked about the two important barbiturates, the thiopental and methoxytal. Let's go to the other group of drugs. We have a major group called non-barbiturate. The only common thing between the drugs in this group is that they don't have a barbituric acid sub-basic unit. So, let's start with Propofol, the one I call the Hulk drug. Okay, it's the Hulk. We will know why now. But Propofol is of a certain family that's different from the family of ketamine and the family of etomidate. The family Propofol has benzyl group and the enol groups. Okay. Let's go back to Propofol. Why would I call it the Hulk? Because for me, it's the most important drug maybe in anesthesia and one of the most powerful drugs, so it's very useful. The second thing, it can cause green urine or hair, and we all know that the Hulk is very greenish. And the last thing, when it's given in extra doses, or if the patient has some problems, it can cause severe catastrophic side effects. Severe side effects. Exactly like the Hulk. He's a good guy, but sometimes he can't control himself and he smashes everybody around him and do bad things. Now, if we go to the effect of Propofol in body systems, we said it decreases everything in the body, including the heart rate. 55 decrease the dose, because people in this age are very sensitive to Propofol, and if you give even the normal dose, the blood pressure will decrease very much, and this might make you have severe, very bad problems. Now, the percentage of Propofol, we have 1%. If we remember, we multiply by 10. This means we have 10 milligram per cc. Now, each kilogram, how much shall we give? Around 1 to 2, or in certain books, 2 to 3 milligrams per kg. Now, if you come to the Propofol ampoule, here, you have the Propofol. We put air because we don't have the ketoenol issue. Now, the Propofol here is in the liquid status. But the problem is that Propofol originally is not liquid. That's why you put it with an emulsion. To force Propofol to become water soluble. This emulsion, you mix it with egg yolk and soybean oil. Okay? So, earlier it was said that if a patient has egg allergy or soybean allergy, don't give Propofol. But after many research and studies, it has been shown that you can safely give Propofol. Why? Because patients who have egg allergy are allergic to the protein of the egg rather than the yolk of the egg, and patients who have soybean allergy, they are allergic to the soybean rather than the oil of soya bean. So we talked about the dose, we talked about the concentration. So we go back here. We said over 55-year-old, you have to be aware. So if we brought two patients, one is 60-year-old and one is 30-year-old, this guy weight is 100 kilograms and this guy's weight is the same, 100 kilogram. You can give this man around 200 milligram Propofol, most likely safely. But here, if you give this number, you might have problems. So in the brochure you will have, or you will read, give less amount of this drug. So you can start, like, for example, with 50 and taper it up to 100. Okay. This Propofol drug also, as we said in thiopental, it have specific features, this Hulk drug. First of all, it is anti-emetic. What does that mean? It prevents vomiting. Okay, it's also anti-pruritic. It prevents itching. And it's anti-sialagogue. It prevents extra salivation. And also, as well, it's anti-epileptic. It prevents seizure. But also, it's epileptogenic. It can cause seizures. It's like the antiarrhythmic drugs in the heart, which prevents arrhythmias, but they themselves can cause arrhythmias, so they are called arrhythmogenic. So the Propofol is both anti-epileptic and epileptogenic. Because it's anti-epilepticus, Antiepileptic, we use it in status epilepticus. Now, what's status epilepticus? Patients who have epilepsy, if they have seizure, within 30 minutes, they should regain consciousness. If they remain unconscious for more than 30 minutes, we call this status epilepticus. Now, these patients are unconscious, they have the risk of aspiration, they can protect the upper airway. So we have to make them sedated and put something called endotracheal tube inside the trachea and the larynx and connect the patient to a mechanical ventilator that will ventilate or make the lungs ventilate rather than ventilating spontaneously by the patient. Here we will help the patient by preventing aspiration until the patient can regain consciousness by himself and go and walk and study by himself. While he is sedated, we need drugs to sedate him. Which ones? We will use ones that have anti-epileptic effects. We have two, the Propofol and the Bentameric. But here we don't give boluses. What is boluses, or what are boluses? Boluses when you give the drug like a push inside the cannula. In these cases, we give these drugs like infusions. You keep giving the drug inside a pump to the patient, and he or she will keep sleeping without epilepsy because these two drugs are anti-epileptic. But the problem here is with Propofol. If you connect or you give Propofol as infusion for a long time, you will have something called Propofol infusion syndrome. In this syndrome, you will have increased lipids and you will have acidosis. In fact, it might lead to death, unfortunately. This syndrome is especially seen in patients less than 15-year-old inside the ICU, the intensive care unit. That's why you should avoid Propofol infusion in pediatric or children patient inside the intensive care unit. Okay, let's move to the next drug, which is ketamine, or the red drug, because it's a helpful drug, yet it's a dangerous one. So if we start by the percentage, you can give 1%, 5%, or 10%, depending on the manufacturer. This is the concentration. The dose, it's around 1 to 2 milligram per kg. But this is the dose for hypnosis, which means loss of consciousness. This is very high for ketamine. Ketamine most likely is used for something called sedation we talked about earlier. Sedation is decreasing the level of consciousness without causing a total loss of consciousness. Here we use less dose. Now, what's amazing about ketamine, we said first it needs 90 seconds rather than 10 seconds to work. The second thing, it's not only given IV, you can give it IM, you can give it rectally, you can give it by many ways. So if you are in an urgent case and you can't put a cannula for a reason here, you just give it in the muscle or rectally. Now let's go back to this information. The dose for hypnosis. When can we use ketamine for hypnosis? Let's say someone is driving his car and he made an accident and lost like 2 to 3 liters of his blood. He comes to the emergency room with a blood pressure of 70/60. 30. If you give him Propofol or thiopental, you might go into a cardiac arrest. But if you give him ketamine, at least you will keep the blood pressure as it is, and most likely you can increase it a little bit. Okay, what are the problems of the ketamine? We said it can increase everything, including the intracranial pressure, the intraocular pressure. It also can cause vomiting, and it increases salivation. So it's a cyanogogue drug. Okay, but the main problem is in the C and S. A lot of you, if you tried ketamine in the hospital, if you know a relative or a friend that tried ketamine, he will say or she that they had a strange case in which they had hallucinations. Even after the operation, they had vivid dreams or even nightmares. This is because of ketamine. Moreover, the ketamine can increase the rigidity of the body. You might not be able to open the mouth of the patient because he's having jaw rigidity, and this is dangerous because you might not be able to insert a tube inside his mouth. Also, it can cause severe cases of rigidity in the whole body, which is called obstetonus, etc. It also can cause or increase the seizure or epileptic activity of the body that ketamine can cause. What's important about ketamine, it's very good bronchodilator. So if we're having someone who is suffering from a respiratory disease in his lungs, the ketamine might be a good choice. Lately, in the latest years, it started to be used to treat depression in psychiatric patients. The family of ketamine, it's a derivative of phencyclidine. So it's different from Propofol, but also different from thiopental. Now let's go to our last important drug, which is etomidate. Now, etomidate consists of imidazole ester. So you bring imidazole, which is originally an antifungal drug, and add an ester group. So etomidate consists of this. What's important about this? Any drug in the world that consists of esters is easily broken to other molecules because esterases, the enzymes that break ester, are widespread in the body, in the whole plasma, blood, and liver. So anywhere the etomidate go, it's rapidly broken into derivatives that can be excreted in the body. So the metabolism, or rather the breakdown of etomidate, is something that is differentiated from the other drugs in our lecture. The other drugs, they are metabolized in the liver, while etomidate is metabolized by esterase. All of the drugs we mentioned are excreted from our body through the renal system in the urine, except one drug, which is methoxytal, that is excreted in the feces. Now, etomidate is rapidly metabolized because it contains an ester group. Etomidate and ketamine, they rarely cause allergy, but their major problem is they cause vomiting, especially etomidate. So if you give someone etomidate, the most thing he will dislike about this drug is the excessive vomiting he had. Now, let's go to the concentration of the drug, it's 0.2%. So each ml has 2 milligram, and the dose is 0.3 milligram per ml. We said that etomidate is a good drug because it neither increases or decreases parameters of the body. That's why it was, and we will say why it was, not it is, one of the most favorite drugs in cardiac surgery. In USA, this drug is no more used in anesthesia for certain reasons. The reason is it works on a certain gland. Which gland? It is the suprarenal gland or adrenal gland. So above the kidney here, we have a gland called suprarenal or adrenal gland, which is affected by etomidate. This gland here has, like, let's say, any fruit or any fruit. It has a shell and a core. We call this cortex, and we call this medulla. Okay, the medulla here, it produces majorly adrenaline and to a lesser extent noradrenaline. Here the cortex, it consists of 3 layers. To memorize these layers, you have here GFR. So GFR. Zona here. Zona, it's a zone, a place. Zona glomerulosa, zona fasciculata, zona reticularis. So glomerulosa, fasciculata, and reticularis. Zona glomerulosa, it secretes something called aldosterone. Fasciculata, it secretes corticosteroids like cortisone. And reticularis, it secretes the sexual hormones. Now, of aldosterone and cortisone in the body. These hormones, especially the cortisone, are very important in stress cases. And they are very important during the whole day. Cortisone is a very important hormone, as well as aldosterone, which prevents the excretion of water as well as sodium. So these hormones are very important. Using etomidate in patients, especially in intensive care, has led to the decrease of these hormones and increase in morbidity and mortality. That's why these drugs are no more used. Some things to add at the end of the lecture. You know that each drug has its own metabolites, which are, if the drug is here, they are small parts of the drug that can be excreted easily. Sometimes these metabolites can be active, but in most of cases they are less active than the parent compound. So which of our drugs today has active metabolites? There are 2, ketamine and thiopental. We have norketamine, in which we move CH3 from ketamine. If you move CH3 from anything, it will become nor. So my name is Layth. If you call me Norlayth, you move methyl group from me. And the other one is pentobarbital. It's the metabolite, or barbitone. It's the metabolite of thiopental. And as we said earlier, it's the original drug of thiopental, but you just switch O to sulfur. Now, Propofol and etomidate has most likely inactive metabolite. One last thing is that of distribution. When you give a drug, the places the drug goes to is called volume of distribution. Some drugs have low volume of distribution, some drugs have high volume of distribution. Now, the drug with highest volume of distribution in our body in today's lecture is a Propofol. So, I hope that you understood the things we talked about in our lecture. I hope now that you can use these drugs safely and understand how they work, their side effects, and I hope even that you can improve these drugs or make new ones maybe. Thank you for watching so much. This is Dr. Laith Abu Mahfouz. I was so happy to giving you this lecture.